I spotted a story in the BBC website back in July, which wasn't particularly related to lung fibrosis, but it led me down this particular rabbit hole I'm going to tell you about now, and I think it's quite useful. I learned a few things from it, so hopefully you will too. So something that we all suffer from is, or all our patients suffer from, is lung fibrosis or scarring of your lung tissue. We've effectively talked about it quite a lot. It's important for CPA patients because the scarring is what is thought to be one of the weak spots for the fungus Aspergillus to attach to and grow. So patients who've had TB in the past will have small scars in their lungs. People with fibrosis, there's people who just experience generation of fibrosis in their lungs spontaneously almost, and possibly as a response to something they inhale. So those people also have a risk factor for aspergillosis, particularly CPA. Bronchiectasis we were talking about earlier, that's a scarred area of lungs, and cystic fibrosis, of course, is a heavily scarred, or it was before the recent medications, a heavily scarred environment. All these people are vulnerable to aspergillosis, and we can see one in there. This is what we talked about X-rays earlier on, and spotting things on X-rays and comparing that to spotting things on CT scans. This is an X-ray of somebody's lungs, and right at the top there is a fungal ball. Now, someone like myself, it's virtually invisible in an X-ray, but in a CT scan it wouldn't be. I think I might have a picture of that. Yes, so you have that was an aspergilloma, and there's a cavity. And these are the cavities as they light up on a CT scan, that in particular. This is characteristic. So you've got your cavity wall, a fungal ball in the middle, and then an air gap all around the fungal ball. They're called a crescent sign, and that is absolutely typical. Nothing else apart from a ball of fungus causes that radiological sign. That's very clearly a fungal ball. Quite often that fungal ball is rattling around in there, believe it or not. It's not fixed. You can lie the patient down and it'll go down to the bottom of the cavity, and stand them up and it'll move. All the rest of these things, I don't think that is a fungal ball. I think that's a blood vessel. But there's some scarring here with these. That's a major blood vessel, but some of these other bits could be potentially scarring. So aspergilloma, strongly linked with scarring, cause scarring, grow on scars. We'd really like to do something about all the scarring that people get in their lungs. The proper medical name for scarring is fibrosis. What is it? So it occurs when the normal repair process of the lung tissue goes a little bit mad. Instead of healing with normal elastic tissue, the body lays down excessive amounts of collagen. And if you've ever cooked a Christmas turkey and picked up one of the legs, those are the rubbery bits that attach the muscles to the bone. So this stuff is quite tough, but it's also very inflexible, and other proteins. Over time, this leads to a stiff, non-functional lung tissue. So what should be a nice, normal, elastic lung tissue becomes stiff and non-functional, which reduces lung capacity. Interestingly, so these are sort of complicated sounding names, but they're just things that initiate gene expression, and that's cytokines and growth factors. Like, for example, transforming growth factor beta, which was originally discovered as part of cancer research back in the 80s when I was working on cancer research. And growth factor interleukin 11, there are probably 2-3 dozen of these things now. And they are imaginatively named IL-1 through to about IL-48. And this is IL-11, so it was the 11th one discovered. these are the growth factors, the things in our body that drive the process promoting the activation of fibroblasts, which are a special type of tissue cell, and fibroblasts make collagen, make scarring. So the scarring is usually preceded by inflammation, which we could probably have guessed. It's only after injury and inflammation do we generally have a scar. So that's kind of stating the obvious. And immune cells like macrophages and neutrophils are recruited to the lung tissue, reducing pro-fibrotic signals. So we've mentioned in the past neutrophils, and those are things that go in there to try and eat invading fungal hyphae. So they are drawn to the infection. Because they are there, they cause inflammation. Because inflammation is there, it switches on IL-11, and because IL-11 is switched on, we get fibroblasts and scarring. So it's not a simple process, but it's quite a predictable process. And this is interesting because these are the first bits I'm learning. I did not know that these growth factors were involved in scarring. A lot of this research is about those unfortunate people who spontaneously generate fibrosis in the lungs rather than people who are infected. Why does it do it? Well, a scar, if you scar your hand, it's a rapid way to close up a wound, which is stating the obvious. Using collagen, and collagen will prevent infection. You covered the wound and restores some of the structure. So you've got a hole in something, it'll cover it up and put a nice tough covering on it. But of course, if you do that in your lungs, what you replace healthy tissue that's been infected or damaged with is non-functional scarring, which isn't great. It's sort of an emergency sticking plaster over a wound, but when it has a long-term consequences, it no longer performs as a lung should, or lung tissue should. Triggered by wounding and inflammation, which is fairly obvious. If the inflammation persists, now that's important because I showed you a picture of a fungal ball, and a fungal ball is essentially an infection that is persisting. It stays there, it doesn't go anywhere. And because it stays there, inflammation stays. The whole area stays quite inflamed for a long time. And if it stays infected, then you're going to get more scarring. So it's going to get worse. And what we see is the scarring effectively walls off the fungal ball from the rest of your body. So it's rescuing your body from that infection by protecting you from it. But again, you've now got a cavity with a tough exterior, which is damaging to your lung function. Okay. Scar tissue is not fully functional. It is actually weaker than something I didn't realize. Scar tissue is not as strong as skin tissue, for example. If you damage your skin and a scar forms over it, then that scar tissue is actually weaker than the original skin. And it's similar for your original lung tissue. It's weaker. It's a weak spot in your lungs. As my grandma would have said, you've got a weakness in your lungs. Well, maybe that's what she was talking about. This lung tissue cannot do all the normal things. Gas exchange, it's not flexible anymore because lung tissue has to be super stretchy. If you try and stretch one of those tendons from the chicken or the turkey, they won't move. And that's why where the tendon is there in the first place, it's like a piece of rope, it won't stretch. Doesn't have any blood supply, which is what's important in this context, because if you don't have much of a blood supply, then you don't have much immune function. So this has effectively become a physical weakness in your lungs, but also a weakness for infection. If there's air from your lungs getting to such an area and bringing fungal spores, for example, into that area, then if the spores land on that scar tissue, there's a greater chance of them being able to survive because there isn't as much of your immune system active in that area. The same happens when TB, if you have TB, the similar sort of thing happens. So it's an emergency repair, but what you end up with is a slightly weakened part of your lung. Fibrosis can happen. Fibrosis scarring can happen throughout somebody's lungs almost spontaneously. This is a normal pair of lungs. Lots of dark areas here, which is where all the air is that this person was breathing in. You see some marks, so these tend to be the large blood vessels. You can see that one running up, a branching blood vessel running up to the heart, which is, well, the heart is this whole area here. Someone with fibrosis, though, like this poor person here, large parts of what was blackness has now become mottled and white, and all that is scar tissue in their lungs. This is someone with idiopathic pulmonary fibrosis. It could have been something they breathed in. Maybe it could even be someone who's inhaled something poisonous like smoke from a fire, and you end up with this in an X-ray and this in a CT scan. So it's really obvious when you see it. We would really love to be able to stop this happening, because all that is loss of lung function, and this person will be struggling to lead a normal life without bottles of oxygen and so on. It would be nice to be able to stop that process, because the process can be ongoing in someone with this particular type of fibrosis. What can we do about it? Well, a little bit like asthma until recently. Corticosteroids are about the only option. If you give people steroids, it suppresses their immune system, it reduces the inflammation, and it can help with reducing scarring, but it doesn't work particularly well. And we all know reasons why we can't use corticosteroids too much in a given patient. So that has severe drawbacks. And then the only other option, or the only other main option, is surgeons can go in and help loosen areas of chronic scarring. But of course, as soon as they go in, they're cutting and they're causing more scarring, so that's not great either. And there are many other options, which is the situation that I was aware of until July. There is research going on, has been for a while. Once we know that IL-11 is part of the problem, then we can start looking at ways to stop IL-11 doing what it does. So this was a particular risk factors. Age. As you get older, you're more prone to fibrosis in these spontaneous forms, not in people with CPA. We're really still talking about IPF, idiopathic pulmonary fibrosis. And we have some of these patients. There are in fact several hundred of these patients between us and the clinics in London who have Aspergillosis. So Aspergillosis is forming on this scar tissue. A lot of those people with IPF did smoke back in the day. So that is another risk factor that we know about. It certainly helps cause fibrosis. Some people are just more prone to it, and we've even got an answer of particular genes to look out for. There are mutations in these genes and they become pretty prone to fibrosis, which is a tough thing to combat. Oops. And last of all, chronic lung injury, which is essentially what people with CPA have. Repeated damage to lung tissue can increase the risk of fibrosis, mostly around the injured area. So we've already said that TGF-beta can turn on this scarring process. IL-11 can turn on this scarring process. Not only turn it on, they drive it. I don't know if I'm going to talk about this later. You might wonder why, if these things are so bad for causing scarring, why do our bodies use them? Well, we'll talk about that in a bit later because they have a broader role. We're only going to talk about IL-11 because that's what was in the paper I spotted in July. Right, so IL-11, there it is. It causes a cascade of effects. It's not a simple process. IL-11 stimulates MEC-ERK, stimulates SASP, stimulates fibroblasts to come out of senescence. In other words, they're asleep and not producing fibers. They're not producing scarring. They're dormant. You can turn them on, and effectively you end up with cells that can produce all this scar tissue originally as a result of IL-11. There's more than one route that they can do that, but it's easy to see that IL-11 is driving both of these routes. IL-11 is a really good candidate for what if we could turn that process off. If we can control it, we might be able to control scarring. Now, scarring is only one thing that IL-11 can influence. There's fibrosis, which is scarring, and loads of different organs can become fibrotic, including lungs, also liver, kidney, lots of other parts of our organs can become fibrotic, and thus non or less functional. It affects our heart. You get a fibrosis of your heart, and this can lead to heart failure. Cancers, it's always there somewhere, isn't it? Cancer. IL-11 is thought to promote tumor growth and metastasis, or spread of cancer cells, by influencing the environment. And this is probably where IL-11 was discovered in connection with cancer, because cancer is better funded than all the other areas of research, and we've been looking for longer. And other inflammatory diseases, like I mentioned somebody this morning, I think, oh no, yesterday, rheumatoid arthritis and inflammatory bowel disease are also have an element of IL-11 causing those inflammatory conditions and that scarring. So it reaches into lots of different illnesses. It will be great if we could control it. And can we control it? Typically, this work has been going on for a while already. The anti-IL-11 therapies involve MABs, monoclonal antibodies, which we're now all familiar with, because those are the types of medication that we're using to fight severe asthma, and with a lot of success. The same technology we could try to use against IL-11. Other types of drug, small molecules, inhibitors, can be used to neutralize IL-11 or block the thing it binds to. So I wonder, I don't think that picture showed us, no, didn't show us receptors. So to work, IL-11 goes in to a cell, to one of those fibroblasts, and it switches it on by attaching to a receptor. If we block the receptor so IL-11 can't attach, then it turns it off. So that's another potential way we can attack the activity of IL-11 and prevent it causing excessive scarring. There are therapies that have been developed to do this. There are 3 different ways we can do it. They're all still in experimental stages. They're just in the preclinical work. They may now actually be in clinical trials on people, on humans, but the only stuff that's available in papers at the moment is stuff that was probably done 2-3 years ago. So only talking about animal models where we studied this and shown that it has an impact. If we can block IL-11, we can have an impact on fibrosis in animal models, which are essentially mice, on both fibrosis, pulmonary fibrosis and heart fibrosis. Blah, 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 blah. Right, so as a result of this research, candidate drugs have been developed. Latin Therapeutics. This is how things are done now. The small companies, and this is done a lot at the university as well. You'll set up a small company which will be largely funded by a friendly drug company to develop candidate drugs, and they then test the candidate drugs, and this is a receptor blocking antibody. And if they get success, then they sell it on to the companies that will develop these drugs into things that end up in a clinic. Blocking the IL-11 signaling reduces fibrosis in lung and skin models, which is exactly what we hoped it would do. So this is looking very promising. This is almost certainly already going into clinical trials, and I think I've got mention of one already, although they are not in the open listing of clinical trials yet, because they're kept quite secret until they know what the results are going to be. Other things that have been used, saracatinib, which is an inhibitor, inhibits SRC kinase. It's a SRC kinase inhibitor. Well, SRC kinase comes from way back in the 70s. It's an oncogene. It causes cancer, and this inhibits it. So you can see that type of a drug could certainly help someone who's got a SRC type cancer. It also targets fibrogenic processes in lung tissue, including fibroblasts. So this is another candidate that has already been developed and needs to now go into human trials probably. And of course, human trials initially are there to check whether these things are going to be toxic to people. So it's quite early days yet, I think. And that's a phosphodiesterase 4 inhibitor, which is another promising candidate, inhibits fibroblast proliferation. And this one actually acts synergistically, which means if you put the two of them together, you get more impact than the two of them separately. So it's not additive, it's synergistic. You get tenfold improvement if you put two things together, for example. And this is with another type of inhibitor. So all of a sudden I've discovered, I've now realized that there's a whole bunch of work and a whole bunch of clinical trials about to start up in this area, which will fundamentally help people who have problems with lung fibrosis and all other types of fibrosis. So what only a few months ago I thought was a pretty much a dead end in research. What can we do with some tissue that's not particularly alive? It's just a rubbery stuff that prevents our lungs working properly. Well, it turns out there's quite a lot. This stuff, incidentally, IL-11, I don't think I'll talk about this later, is not produced much in young people or young organisms, young animals, and gradually accumulates as we get older. So it's almost as if one of the reasons we get older is we get more and more prone to fibrotic change as we get older, because there's more and more IL-11. So really sort of opens it up and so how much we could all benefit as we get older from just taking one of these drugs from about age 50 onwards. And that is actually discussed in one of these papers. But they didn't think that was a good idea at the moment, but who knows in the future. This is the paper that I read that stimulated all of this inquiry in the summer. These are two little mice. These two mice are the same age. Well, that one definitely doesn't look as well as this one. They're identical age, treated identically, had the same life. The only difference is this one doesn't produce, in this case, this one has been given one of the anti-IL-11 drugs that are under test. And you can see not only does it inhibit fibrosis and scarring, it actually, which is the point of these headlines, it actually holds back aging. So this is much bigger than just helping your fibrosis in your lungs. It's helping fibrosis everywhere, and it's actually elongating the life. These mice live 20 to 25% longer than normal mice who experience IL-11 without inhibiting it, which is extraordinary. This is unexpected. This is a published paper in Nature in July, so it's a good paper. Also, these mice are younger. They're much less frail. They've got better breathing. They can run around better. Their bones and their joints and everything are in better condition than a normal mouse. They really do seem to be effectively, functionally younger because of the ability to stop IL-11 having its impact on those mice. Okay, largely said that IL-11 is low when we are born and gradually accumulates. There's even a suggestion that this is something that is a leftover from when we evolved for over a long time. Human Homo sapien history is around about 1 million years now, I think. And we continue. We didn't used to live as long as we do, so we never really, and we don't reproduce obviously after a certain age, so there was no point in getting rid of IL-11. It was just delaying the amount of IL-11 we produce to a point where we would no longer have children. Would probably be as much as we would see, and that seems to be what happens. We don't have much when we're born, and we get lots more by the time we get elderly. These trials, this work has been done on mouse cells before they did gave this mouse the anti-IL-11. They tried it on mouse cells first, and they measured certain reactions, and it had that effect. But at the same time, they measured them in an identical way on human fibroblasts in the laboratory, and they got exactly the same things happening to those cells as we got for mouse cells. So it argues that if all goes well, if we give an anti-IL-11 drug to humans, it should have a similar effect as it does to this mouse. Obviously, this is a big deal. You can imagine rich people rushing out for this elixir of life, even as we speak. But there's a long way to go yet, I should think, to make sure it's safe, essentially. How are we, if these things allow us to live for 20 years longer, it's going to take 50, 60, 70 years to work out whether it's doing that safely or not in humans. So it's a hugely encouraging, but also quite technically difficult thing to work with.